Okay, so today our topic is discussing mitral valve disease. So before starting the actual topic, let's review the rheumatic fever. I think you all know that the rheumatic fever is an autoimmune disease caused by streptococcal infection, cross-check between streptococcal antigens and structural glycoprotein of heart, joints, central nervous system, and connective tissues. And usually we diagnose rheumatic fever on the clinical basis. We have major criteria and then minor criteria. If the patient has rheumatic carditis or arthritis, Sydenham's chorea, deformity of skin, subcutaneous nodules. So these are the five major manifestations of rheumatic fever. So if the patient has one major and some of them minor, then you can diagnose rheumatic fever confidently. And if the patient has two of these major criteria, then again you can diagnose rheumatic fever. And minor fever, arthralgia, raised ESR, CRP, prolonged PR interval, these are the minor criteria. Raised EOCT, raised ESR, CRP, troponin T, troponin I, and hemoglobin A, these may be elevated in rheumatic fever. Why do we discuss rheumatic fever? Because in our part of the world, the majority of cases, the cause of valvular heart disease is rheumatic fever. So in our part of population, rheumatic fever is the number one cause of valvular heart disease, whether it is regurgitation or stenotic lesions. The rheumatic fever is the major cause. So let's discuss the mitral valve disease. Mitral, as you know that the blood comes from the pulmonary veins into the left atrium, and then through the mitral valve that is located between the left atrium and left ventricle. Through the mitral valve, it comes into the left ventricle in diastolic phase. In diastolic phase, then the mitral valve is open. The blood comes from the left atrium into the left ventricle. Then in systole, when the heart contracts, this mitral valve is closed, and aortic valve opens, and blood pumps out into the system. So this is the normal hemodynamics. And you know that the mitral valve has got two leaflets, an elongated anterior mitral leaflet, it's a bigger one, and the posterior mitral leaflet, which is a shorter. There are two leaflets in mitral valve. In mitral stenosis, the orifice is going to narrow. It becomes narrowed down, and there is a very less space for the blood that goes from the left atrium into the left ventricle. So this orifice becomes narrowed, right? And then there is a pooling of the blood into the left atrium. So there is a stasis, there is pooling in the left atrium. The left atrial pressure is raised, and then when it is so raised, it is so much high, then the blood, becomes going back into the pulmonary veins. So there is a pulmonary venous congestion and alveolar leakage, and patient goes into pulmonary edema. So this is the pathophysiology, right? So let's talk about the etiology of the mitral stenosis. As I have mentioned earlier, that the rheumatic fever is the number one cause of mitral stenosis or any of our valvular heart disease. But there are rare causes of mitral stenosis like congenital rheumatoid arthritis, and in SLE you can find mitral stenosis, and then infective endocarditis when there is a large vegetation that obstructs the way of the blood from the left atrium into the left ventricle. So it's actually the obstruction of the orifice. There's a thickening because it's a inflammatory disease. There's a thickening of the leaflets, and then there's a shortening, adhesions of the leaflets. Then in chronic infection, there is a calcium deposition and scarring. And we have 4 forms of fusion of these valvular apparatus. So we have commissural fusion, and because of commissural fusion, again the orifice has become narrowed, and the cuspal fusion, then the chordae, and sometimes combined mixture of all these 3 fusions. If you see the mitral valve, it has got 4 things that you should remember: the leaflet, and this is the leaflet. This is anterior mitral leaflet, and this is the posterior mitral leaflet. And on both sides, these are the commissures, right? So if the commissures are fused, you can imagine that the orifice is narrowed down. And these are the papillary muscles, these 2, the papillary muscles, and these are the chordaes, these 2 chordaes attached to the anterior mitral leaflet and the posterior mitral leaflet. So the commissures and the leaflets and the chordae and papillary muscles, these are the 4 things of altogether we can call them mitral valve apparatus. So these are the 4 things. Any pathology that damages either the papillary muscle, the chordae, the leaflet, or the commissure, that can cause the mitral valve disease. The pathophysiology of the mitral stenosis, as I have mentioned earlier, that there's a pooling of the blood into the left atrium, and there is a stasis. The left atrial pressure is high, and the blood goes back into the pulmonary veins, and it causes pulmonary edema. The normal cross-sectional area of the mitral valve is 4 to 6 centimeters square. If you categorize the severity of the disease, you can divide the mitral valve stenosis into mild MS and moderate MS and severe MS. This is the older classification actually. So less than 2 centimeters square, left atrial pressure is raised, then left atrial hypertrophy, and this is usually the compensated period of the mitral stenosis, and usually patient does not come to the clinician, and this is actually the asymptomatic phase of the disease. Then moderate MS, less than 1.5 centimeters square of the mitral valve area, and in this case, pulmonary venous pressure is high, pulmonary capillary wedge pressure is high, and in this phase of the disease, patient has started become symptomatic, and he or she comes to the clinician with exertional symptoms. Actually, the exercise tolerance of the patient has become markedly decreased, and he becomes symptomatic while on exertion. So at rest, patient may be asymptomatic, but on exertion he got symptoms. Severe MS, less than 1.0 centimeters square, pulmonary arterial pressure increase, RV overload, and maybe patient may have signs of right ventricular failure, and this is the advanced stage of the disease actually, right? So this is the when we categorize the patient, the severity of the disease, the mitral valve area is the most reliable method. On the basis of mitral valve area, we can divide the patient into 3 categories. as I mentioned, that less than 2 centimeters square, 1.5 centimeter, and 1.0. But now there's a newer classification that comes in, and in newer classification, we have divided the disease into a progressive MS and the severe MS and a very severe MS. And if the patient has got less than 1.5, more than 1.5 centimeters square of the mitral valve area, right? So it is called progressive disease. And from 1 to 1.5 centimeters square, it is called severe disease. And less than 1.0 centimeters square, it is called very severe disease. So in newer classification, the division has changed, and now we call progressive MS, severe MS, and very severe MS. So progressive MS is when the mitral valve area is more than 1.5 centimeters square. 1 to 1.5 centimeters square, it's severe MS. And if the valve area is less than 1.0 centimeters square, it is very severe. Now, the usual clinical manifestations are cough, hemoptysis, dyspnea, palpitation, chest pain, and hoarseness of voice. So, as I have mentioned, the pathophysiology of the MS, and when there is a left atrial pooling of the blood, and when the blood goes back into the pulmonary veins, and there is a leakage of blood volume into the alveoli, then patient has started coughing and hemoptysis, and he becomes breathless because of raised catecholamine activity. There is a palpitation and chest pain, and when there is a left atrial hypertrophy and so much left atrial hypertrophy, left atrial dilatation actually, then this left atrial dilatation can compress the left recurrent laryngeal nerve, and because of that compression, patient may have hoarseness of voice, and this is called hoarseness.
Recording in progress.
But the diastolic rumbling murmur, this is a very important finding. If you have MS and if you're going to diagnose the MS on the clinical grounds, then you must have this diastolic rumbling murmur. It's a very typical murmur, diastolic rumbling murmur at the apex. And in case of advanced stage of the disease, if the signs of pulmonary artery hypertension are there, then you may have loud P2 and the left pectoral heave and the systolic murmur of the TR over the left pectoral area, and Graham Steele murmur of PR may be there. Now, how can you diagnose, how can you investigate the case of mitral stenosis? First of all, ECG. If you have the ECG of your patient, then there may be signs of left atrial enlargement. And how can you see the left atrial enlargement on the ECG? So you should look at the P wave. If the P waves are there, then you should look at the morphology of the P wave over the ECG. and what are the best leads of the ECG to look at the P wave, the morphology of the P wave. The best leads are lead 2 and or lead V1. So if you see the lead 2, you will have a prominent P wave, right? Or if you look at the V1, you will have a biphasic P wave. So if the biphasic P wave are there, or the tall and broad P wave over the lead 2, then you can diagnose the left atrial enlargement. So left atrial enlargement is one of the signs of mitral stenosis over the ECG. But usually in the advanced case of disease, you may not have P waves because the patient has developed atrial fibrillation. And in case of atrial fibrillation, P waves are absent. P waves are no more there in case of atrial fibrillation. And then you may have the signs of right ventricular hypertrophy over the ECG. So these are the 2-3 findings over the ECG. And if you have these 2-3 findings over the ECG, you may have some idea about the disease. And these are actually the supporting findings for your clinical diagnosis. Again, the X-ray, you cannot confirm the diagnosis over the ECG or over the X-ray, but you may have some supporting findings for your clinical diagnosis. So changing cardiac salute, again, the left atrial enlargement, RV enlargement, mitralization, pulmonary venous congestion, and curly B lines of the pulmonary edema. So on X-ray, you should see this left border of the heart, right? And if you have the straightening of this left heart border, this is called mitralization. The straightening of the left heart border is called mitralization because of pulmonary artery fullness and the left atrial enlargement. So this border has become straight in case of mitral valve disease. You can see the X-ray. This straightening of the left heart border. This is called mitralization, right? And the right ventricular hypertrophy, in case of right ventricular hypertrophy, this apex becomes rounded and lifted upwards. So this is one of the signs of right ventricular enlargement. And if you see carefully, you can see the double heart, the double contour, the double border of the right side. This one, this shadow, and if you see carefully, this shadow. So this double shadow is because of left atrial enlargement. This is all left atrium. This is left atrial enlargement. This is left atrium, and this is the right atrium. So this is again one of the findings of the mitral stenosis or left atrial enlargement. Now ECG, in many of mitral valve disease cases, you will have atrial fibrillation. So how can you diagnose atrial fibrillation over the ECG? You should look for 2 things: varying RR interval, right? And long lead to varying RR interval. R to R interval is variable. You can see easily over there, right? And absent P wave. No definite P wave are there. Okay, no definite P waves are there. So if the P wave is absent and R to R interval is variable, then you can diagnose easily the atrial fibrillation. These are the 2 things that you must have for diagnosing atrial fibrillation. But to confirm the diagnosis, you must have echocardiography findings. You must go for echocardiography to confirm your clinical diagnosis. and by echo you can easily see the mitral valve leaflets, mitral valve commissures, chordae, papillary muscle, everything, left atrial enlargement, everything. So this is the imaging modality, and this is a very good modality or diagnostic for the mitral valve disease. So we have M mode on echo, two-dimensional echo, and then Doppler. So this is the 2D echo, two-dimensional echo, and the mitral valve is normal over there. So you how can we do the echocardiography? The probe, we usually probe the disease, and we put the probe over the sternum. So this is the sternum, and we put the probe over there. So for the first structure that we can see is the right ventricle. This is the right ventricle. Okay, and then this is the septum. Then this is the left ventricle. Okay, right ventricle, septum, left ventricle, and this is the mitral valve. This is the posterior mitral leaflet, and this is the anterior mitral leaflet. This is left atrium, and in between, what is the structure? This is the aorta, and this is the aortic valve. Okay, this thin line it's close actually, right? Because this is the diastolic phase. Why I'm saying that this is diastolic phase? Because the mitral valve is widely open. Okay, the mitral valve is widely open. You can see this atrial anterior mitral leaflet and this posterior mitral leaflet. This is left atrium, and blood is going towards the left ventricle in diastolic phase, and this valve is closed, aortic valve. Okay, so this is the normal mitral valve. It is widely open. There is no narrowing, nothing. And this is the rheumatic mitral stenosis. Again, this is right ventricle, septum, left ventricle, and left atrium, aorta. And you can see this is again the diastolic phase, but you can see the anterior mitral leaflet over there and posterior mitral leaflet over there, and then it's a very narrow orifice. This is deceased. This is mitral stenosis. You can see the doming of the anterior mitral leaflet, doming of the posterior mitral leaflet, and very narrow space. The blood is hardly going into the left ventricle. There is a pooling of the blood in the left atrium, the left atrial dilatation over there. Okay, so these are the typical findings of mitral valve stenosis on echocardiography. This is the 2D echo, and this view is called parasternal long axis view. This is the short axis view of the mitral valve, and in this short axis view, the typical finding is fish mouth appearance. Okay, this is actually the mitral valve orifice, and in this view, we can measure the mitral valve area. We trace this, and by tracing this orifice, we can have the idea about the area of the mitral valve. Okay, this is M mode, and this is the 4-chamber view of the rheumatic mitral valve stenosis. And in this 4-chamber, this is left ventricle, this is right ventricle, this is left atrium, and this is the right atrium. And you can see the size of the left and right atrium and size of the left ventricle and right ventricle. Normally, the size of the left ventricle is much more than the left atrium. But in case of mitral valve disease, as I have mentioned earlier, there is a pooling of the blood into the left atrium, and left atrium has become dilated. In case of chronic mitral valve stenosis, you can see there is huge dilatation of the left atrium. This is the joint LA actually. almost the double or triple of if you compare the size of the left ventricle. And this is a stenosis of the mitral valve. Diagnosis and differential diagnosis, diastolic rumble, as I have mentioned, that diastolic rumble is a typical finding of the mitral valve stenosis. And an X-ray flame, ECG, echo, you can have the findings, supporting findings, and you can confirm the diagnosis on echo. But clinically, what are the differential diagnoses of this diastolic rumble? Diastolic rumble or diastolic murmur. You can have diastolic murmur in case of left atrial myxoma, right? And if there is a large vegetation over the mitral valve, then you can have the diastolic murmur. Similarly, you can have Austin-Flint murmur in case of severe AR. You can have the flow murmur during diastolic phase over the apex, and this is called Austin-Flint murmur. So these are the differential diagnoses of the diastolic murmur over the apex. So you should not confuse if you have diastolic murmur, and if you don't have supporting findings, if the LV is enlarged and the patient has got fever, and if you don't find the other findings of stenosis, then you should know that there are other diseases that can present like mitral stenosis, and they may have diastolic murmur. But in our setting, the most common thing is the mitral stenosis. Mitral stenosis is very common among the valvular heart disease. So if you have diastolic murmur over the apex, you must investigate the patient for mitral stenosis. If you leave it untreated, so what may be the atrial fibrillation, as I have mentioned, in very advanced stage of disease, treated, atrial fibrillation may be there. Then acute pulmonary edema, again, explain the pathophysiology, congestive heart failure, thromboembolism. Thromboembolism is a very, the definition of the mitral valve stenosis because of stasis to the left atrium. And if the atrial fibrillation is this stasis, this stasis can cause transform into the thrombus in the clot formation, and clot become dislodged from the atrium. It can go anywhere in the system, and mostly in the cerebrovascular system, and can cause stroke, can cause limb infarction, can cause renal infarction, mesenteric infarction, wherever it goes, cause. So mostly it can cause it causes cerebrovascular disease and stroke and the hemiplegia. The patient may present with hemiplegia. If the patient is the young patient, if you find the young patient with hemiplegia, stroke, and if you auscultate the patient, if you have diastolic rumble over the apex, then the usual cause is thromboembolism, and it's the left atrial clot is the culprit in this kind of cases. Then again, infective endocarditis is one of the complications of mitral valve disease. How can you manage your patient? Medical treatment includes antibiotics, diuretics, and digitalis to control the rate in case of atrial fibrillation. And similarly, antiarrhythmic drugs, beta blockers and calcium channel blockers. And you need to anticoagulate your patient in case of atrial fibrillation to prevent the patient from this thromboembolism and cerebrovascular infarction. So you need to anticoagulate your patient to prevent this complication. medical treatment and the percutaneous treatment, if the valve is suitable for balloon, calcified, and if there is no associated, if there is no clot in the left, then you can manage your patient with balloon valvuloplasty. What we do in case of balloon valvuloplasty, we put the catheter into the venous system through the femoral vein. We go into the inferior vena cava and then right atrium. Then we do the septal puncture, and through the atrial septum we go into the left atrium, and then we cross this mitral valve, and then we put a balloon across the mitral valve, and then we inflate that balloon. Right? You can see this. The balloon is inflating more, and you can see this waste. This waste is the reflection of the mitral valve stenosis, and this is going to open. Right? This waste, you can see the neck over there, and over there it is going to dilate. Right? It's going to open this mitral valve orifice. This narrowing is going to vanish, and you can see there is very minimal narrowing remains over there. So by inflating this balloon, we are able to open the this closed mitral valve, this narrowing. We can manage this narrowing by inflating this balloon. So this is called balloon valvuloplasty. Again, this is the diagrammatic representation of the same procedure, balloon valvuloplasty. The catheter is going into the right atrium, then the septal puncture, and left atrium, and across the mitral valve, the balloon inflating, and you can see the mitral valve is open now. Same thing. Okay, and if the valve pathology is not suitable for valvuloplasty, if the valve is heavily calcified, and if there is associated MR, then the surgical treatment, you can manage your patient with surgical replacement of the mitral valve. Okay, mitral valve replacement is the another choice for treating the mitral stenosis. Now, what is the mitral regurgitation? As I have mentioned earlier, that blood comes from the pulmonary veins into the left atrium, and through the mitral valve it goes into the left ventricle in the diastolic phase, and then in systolic phase the mitral valve is closed and blood pumps out into the aorta. Okay, but if there is mitral regurgitation, in the systolic phase, the blood leakage is back into the left atrium. So some of the blood in systolic phase goes towards the aorta, and some of the blood goes towards the left atrium in case of mitral regurgitation. But it depends upon the severity of the disease, how severe the disease is. If the mitral valve regurgitation is severe, much of the blood goes towards the left atrium. So in systolic period, blood flow back from left ventricle to left atrium in case of mitral regurgitation. Again, the left atrial filling pressure becomes increased, and there is pulmonary venous congestion. In diastolic period, LV accepts more blood, LV dilatation, hypertrophy, left ventricle ejection, left ventricle and diastolic pressure has become increased again. So this is the difference. In both of these mitral valve diseases, the left atrial pressure has become increased. But in case of mitral stenosis, there is no change into the left ventricle. In case of mitral regurgitation, left ventricular diastolic pressure is also increased. So left ventricular dilatation is there, left ventricular hypertrophy is there. So both of these chambers, in case of mitral regurgitation, left atrium is also enlarged and left ventricle is also enlarged. But in case of mitral stenosis, only left atrial enlargement is there. Clinical manifestations of the mitral regurgitation symptoms may be asymptomatic and mild disease. Only palpitation, fatigue, dyspnea is there. It depends upon the severity of the disease. Apical impulse, you can have the prominent palpable apex beat here, heaving type, and cardiac dullness, the signs of left ventricular enlargement also there. And then this is the most important finding. In case of mitral regurgitation, this is pansystolic murmur over the apex that radiates usually towards the axilla. So this is the most typical finding of the mitral regurgitation. Pansystolic murmur over the apex that radiates towards the axilla. In case of mitral stenosis, you must have diastolic rumble. But in case of mitral regurgitation, pansystolic murmur over the apex. Systolic murmur, right? ECG, again the left atrial enlargement, signs of left atrial enlargement, and AF may be there. But what is the difference between the mitral stenosis and mitral regurgitation? In case of mitral regurgitation, signs of left ventricular hypertrophy are also there on ECG. Similarly, on X-ray, mitralization, and again along with the mitralization, signs of left ventricular enlargement also there. Echocardiography, again, this is the diagnostic, and you can confirm the diagnosis, the diagnosis of mitral regurgitation on echocardiography. So you can see this is the X-ray of advanced stage of mitral regurgitation, and you can see this left atrial enlargement and left ventricular enlargement. Apex is going towards leftward and downward. Okay, and again the double contour, left atrial enlargement, right atrial enlargement. Arteries, prominent pulmonary arteries and congestion over there. The vascularity, you can see the prominent vascularity over the X-ray. So this is the X-ray of the heart failure with severe mitral regurgitation. Parasternal long axis view over the echo, right ventricle, left ventricle. You can see the enlargement of the left ventricle, enlargement of the LA, and the coaptation of the leaflets are not proper, and this is the reason of leakage in back of the blood from the left ventricle into the left atrium in systole. The color Doppler is most diagnostic, and you can assess the severity of this leakage, this regurgitant volume from the left ventricle into the left atrium. You can see this is the mosaic pattern, this yellowish and green and blue. This is the mosaic pattern. This is the leakage of the blood from the left ventricle into the left atrium. You can see this in systolic phase. This mitral valve has to close, right? Has to close properly, so that the blood, all the blood, can go towards the aorta. But because of this improper closure of the valve, because of the disease that damages the leaflet, the coaptation of these two leaflets are improper, and because of this improper coaptation, this improper closure of the valve, the blood, there is leakage of the blood from the left ventricle into the left atrium, and you can see this leakage. This is striking the jet striking into the pulmonary veins. This is directly going into the pulmonary veins. This is the sign of the severe mitral regurgitation. You can see the dilatation of the left atrium. This is the atrial septum, and this is the right atrium. So how can you diagnose systolic murmur at apex? And again, there is a differential diagnosis. Ventricular septal defect. Again, in ventricular septal defect, there is a systolic murmur over the left parietal area. In PDA, you can have the systolic murmur, but again, in PDA, there is systolic as well as diastolic murmur in PDA. Tricuspid regurgitation, again in tricuspid regurgitation, systolic murmur at the left and aortic stenosis, there is ejection systolic murmur. These are the. If someone asks you the differential diagnosis of the systolic murmur, you must know that in VSD there is systolic murmur, in PDA there is systolic as well as diastolic murmur, in tricuspid regurgitation there is systolic murmur, in aortic stenosis again there is a systolic murmur. But the character of the murmur in all these diseases are different. In case of systolic murmur of the mitral regurgitation, it's a pansystolic murmur, and usually you can find it over the apex, and it radiates towards the axilla. So these are the typical character of the systolic murmur of the mitral regurgitation. In case of VSD, there is a harsh systolic murmur over the left lower parietal area. In PDA, as I have mentioned, that usually there is a machinery-like murmur that is called machinery-like murmur, PDA, in PDA, systolic as well as diastolic murmur. In tricuspid regurgitation, again the murmur is maybe pansystolic, but at the lower sternal border. And there is a variation and in inspiration and expiration and the quality of the murmur. If you auscultate carefully, the quality and the intensity of the murmur is changing in respiratory phases. In aortic stenosis, there is an ejection systolic murmur over the base of the heart, over the aortic area, and not over the apex, not over the left parietal area. Usually, of aortic stenosis, the systolic murmur is ejection murmur, the aortic area of the heart at the second intercostal space. Medical management, diuretics, surgical treatment includes mitral valve repair, and one you have to replace the valve with the metallic or tissue valve. So this is valve, bileaflet. In severe mitral regurgitation, you have to replace, and most of the time it's metallic. This is another metallic valve is valve, but it's become obsolete now, and usually we are using this bileaflet Metonic Hall metallic valve. So you, in surgical replacement, you have to put this metallic valve at the mitral valve area, okay, and when in diastolic phase, these leaflets are open and blood goes from the left atrium into the left ventricle. But in systolic phase, with the pressure of the blood, these leaflets becomes closed. So this is how this mechanical valve is working. Okay, I think it's enough for today. Okay, over to you, Junaid. Junaid, are you there? Hello, Junaid, are you there?
अस्सलामुअलैकुम।
जी जुबैर,
मुझे जो लग रहा है
is everything okay?
जी सर।
Is everything okay? I'm finished.
सर एंड कर दूं सर क्लास?
हाँ, कोई क्वेश्चन तो नहीं है?
नहीं सर, कोई क्वेश्चन तो नहीं है अब तक।
ये सेशन ठीक गया है? साउंड वगैरह ठीक था?
जी सर।
साउंड ठीक था? क्योंकि मुझे आपकी आवाज ठीक नहीं आ रही है। आप लोगों को मेरी आवाज आएगी?
जी जी सर। सर चैट तो मना है ना सर? चैट का तो मेल आई हुई थी सर, तो
हाँ
चैट
ठीक
तो
है,
मना है।
नहीं चैट तो मना है, लेकिन आपको मेरी आवाज ठीक आ रही है?
जी जी सर, मेरे पास बिल्कुल सर आवाज बिल्कुल ठीक आ रही थी सर।
हाँ, आपकी आवाज क्योंकि क्लियर नहीं है मुझे, तो आई डोंट नो इफ आई एम एबल टू कन्वे माय मैसेज।
यस सर।
ओके, ठीक है,
ओके
थैंक यू
ओके।
सो मच।
वेलकम सर, अल्लाह हाफिज।
अल्लाह हाफिज।